Hello and welcome to our webinar on the new practice guidance for Wilson disease. I'm Rhonda Rowland and I'll be your moderator. I'm on the board of directors for the Wilson Disease Association, and this year the WDA celebrates its 40th anniversary. It all began back in 1983, and it's the same year that I was diagnosed with the rare genetic liver disease. At that time, it was difficult to find any information on my disease. Thankfully, that's no longer the case. This new guidance is the most up-to-date communication yet that's published by the American Association for the Study of Liver Diseases, or AASLD. It provides the latest scientific information on diagnosis, treatment, and monitoring. It was put together by an international team of 9 experts in Wilson disease. A team that not only includes liver specialists, but a copper expert, a dietitian, a neurologist, and a psychiatrist. We are pleased to be joined by 2 of these experts, Dr. Michael Schilsky and Dr. Eve Roberts. They are the co-first authors. Dr. Schilsky directs the Adult Liver Transplant Program at the Yale School of Medicine, and he also directs Yale's Wilson Disease Center of Excellence. Dr. Eve Roberts is a pediatric hepatologist from Canada, and she was also part of the Toronto team that identified the ATP7B gene for Wilson disease. Thank you both for being here today.
Thank you. Thank you for inviting us.
So first of all, we'll begin with you, Dr. Roberts. This guidance is innovative in a number of ways. And one way is the team approach. Why is that significant?
Well, this was a very good idea that Dr. Schilsky brought forward, and it makes it very evident in a practical way that Wilson disease is a multi-systemic disease. It usually involves the liver, but it can certainly involve other organ systems such as the neurological system. You can have psychiatric features, and we just felt it was time to bring everybody together and have a consensus viewpoint from an expert point of view.
Okay, and Dr. Schilsky, this guidance was written for doctors and other healthcare professionals. So how would you suggest that patients and caregivers use it?
There's a great deal of information that's there, and it will be difficult for the average patient to read, digest some of the heavier parts of it. But the important part is that they know it's there and that they can then share with their providers the fact that there's a place to go where they may be able to obtain all the information they need on the different aspects of care.
And for those joining us on this webinar, if you haven't already downloaded the guidance, you can find it on the WDA's website under Diagnosis, which is under the Do I Have Wilson Disease tab. And also a reminder that the doctors will be taking your questions during the second half hour of the program. So if you have a question, please type it into the question box on the left-hand side of your screen. So perhaps the most challenging part of Wilson disease is actually getting the diagnosis. So Dr. Roberts, can you actually see the KF rings without a slit lamp? And how often are these rings seen in patients?
Well, thanks for asking that question. As you can imagine, you can see them from time to time, especially in television shows, in textbooks, and in professors' lectures. But the vast majority of the time, you need something called a slit lamp examination in order to see them. And sometimes with children, you need 2 or 3 slit lamp examinations. I think anybody who's had one of those can imagine the difficulty of getting a good look in a 4-year-old. So that's one aspect of it. Yes, you do need a slit lamp examination. Now, the other part is that often with hepatic Wilson disease, you don't have Kaiser-Fleischer rings forming yet. So in children, less than half will have the Kaiser-Fleischer ring. And even in adults with a hepatic presentation of Wilson disease, it's about 60%. So it's kind of a 50-50 chance. However, if there's established neurological disease, then more often than not, you will also have a Kaiser-Fleischer ring.
When you think about a particular diagnosis and you put the pieces together, the more pieces you have, you increase your what we call the pre-test possibility before you go in and do the specific tests.
There were like the three forms of kind of how Wilson disease can manifest there, and there can be that kind of overlap. What is the spectrum of disease that should be looked at when a patient is diagnosed?
Yeah, this is often a great challenge, and many people, whether you call this a chameleon or a great mimicker of other diseases, is a matter of choice of words. But the spectrum is very wide, and what we call the phenotype, or how the disease presents and the signs and symptoms that patients have, vary a lot. My colleague Eve had alluded to the more liver aspects in the younger patients, which is true. And then over time, with the development of the copper accumulating in the central nervous system, we then to see the overlay of neurologic and or psychiatric symptoms that may occur. Now, some patients, interestingly, only manifest one aspect of it or have one aspect be more dominant than others. And this is often the great challenge in getting to the diagnosis. We're not always presented with the classic findings.
So, Dr. Roberts, most of those who are joining us probably already do have the diagnosis of Wilson disease. What does the guidance say about family screening?
Well, that's a really important question. And first of all, it's important to understand that while we say casually or in easy language, it's family screening, it's actually first-degree relative screening. And the important thing to remember is that your first-degree relatives are not only your brothers and sisters, but your parents and your offspring. So that does make it sometimes very difficult because some of your first-degree relatives aren't born yet, or perhaps some of your first-degree relatives have passed on, or think that they have other health problems and they're kind of too old for Wilson disease. So it's really important to screen all those first-degree relatives, both sort of the horizontal ones and also the vertical ones.
Okay, well, we know once the diagnosis is made, the next step is treatment. So, Dr. Schilsky, where do you start with that? We have 3 FDA-approved treatments for Wilson disease. How is the decision made?
Well, let me comment. We have treatments, but we have to look more globally with respect to the patient as well, and have to consider the other aspects of care, for instance, diet and restricting copper, also symptomatic treatment if patients do have the other aspects of the disease, mental health or bad tremors or such. But when we get down to it, ultimately what we want to do is to control the copper, which is accumulated to excess. Now, there's a more radical approach to that, which is liver transplant, and we reserve that for patients who really are not eligible for or failing medical therapy. And those are, in that case, you replace the liver, and actually you're doing sort of what we like to say is a gross form of gene therapy, in that you're putting a liver with a normal copper transporter into place. And then they do not have Wilson's disease per se, but then they have what we call transplant disease and have to deal with all the different medications and immunosuppressives that are used in that for a lifetime. But back to the medical therapies, we have approved drugs which fall into 2 categories: the chelation therapy, which are those that bind copper and help remove copper from toxic sites and then take it out of the body. And then we also have zinc, which acts to block copper indirectly by stimulating molecules which bind the copper and then keep it from getting inside the body, and also may absorb in the body and also stimulate these same chelators in other tissues to give us an increased capacitance for the metal. And it's important to really separate out as to whether a patient has symptoms, has signs of tissue injury, because we approach that a little differently, a little bit more aggressively in trying to get the copper out, and would aim towards the chelation therapies, which include depenicillamine and trientine. And these are the medications that have been approved, although slightly different in their approvals. And then zinc is more typically used for maintenance therapy, although the chelation therapies, if you use them at a higher dose, make very good initial treatment. And then you adjust the dose as time goes on once stability is achieved, and then you can use those as maintenance therapy as well. Some of the choices are very dependent around the world. Not all are equally available. And there are also different experiences in different countries and different physicians with some of them. So they may feel more comfortable with one or another. But the point of guidances and guidelines are to try to gain a consensus amongst experts, at least how to approach it and how to choose. And so within the guidance, we have the choices of medications, talk about how to pick a dose for that particular medicine, and then how to follow it further down the line.
And Dr. Roberts, are these considerations different in the pediatric population or adolescents, or once patients are diagnosed, say, in early adulthood?
Well, yes, they are to some extent. First of all, we're still learning about the best way to treat infants who have been diagnosed either before birth or shortly after birth who have Wilson disease, because they may not really have any manifestations of liver damage or any other damage. And we have to be respectful of the need for copper, for example, for the development of certain systems. So that's on a case-by-case basis at this point. In children, as a rule, you have to tailor the drug therapy to what they can actually take. So very young children clearly have trouble taking pills and capsules. So again, we have to work around that. But the general guidelines are the same. You would like to eliminate the buildup of copper if it's occurred, or prevent it from happening. So we can juggle the diet and the treatments accordingly.
It's pretty incredible that we've been able to diagnose some patients before birth. It's really, really amazing. Dr. Schilsky, is treatment different for the newly diagnosed patient versus those who are considered stable? And at any point, can you switch treatments?
Yeah, thanks for asking that. It actually, one of the upgrades on our current guidance compared to where we were looking at previously is really talking about treatment in what we call phase of disease dependence, so that we address more aggressively perhaps the initial therapies to reach that stability, and then secondarily talk about the second phase, similar to those of patients who've never experienced symptoms, if they're lucky to be found sort of asymptomatically or before symptoms develop. In that case, what you're trying to do is prevent the onset of symptoms, whereas in those with symptoms or tissue damage, you're trying to first stabilize, and then you're trying to reverse that and bring that into a mode of where you can then go towards that maintenance and then prevention of new onset or worsening of disease. So in the early phase, we talk about, for those who are super severe, the possibility of using combination therapy, which has really not been studied in a prospective manner, but has been used by a number of centers, and there are case studies of publications with that, and a number of us have some experience where we are using both different class of drugs to try to prevent the absorption of copper, at the same time trying to remove copper from the toxic sites. And in the more standard therapy, though, we don't feel that same urgency sometimes to mix and match the therapies, which are a little less proven in terms of studies, and therefore we can just adjust the dose of a single agent. And as long as that agent is being tolerated and is achieving the goals that we set for it, both clinically and biochemically, to achieve that stability. In other words, if somebody is very symptomatic, you want those symptoms to abate. If they have very high liver tests, you want those numbers to reach a certain level so that we can say that we've achieved a much better state, less injurious to the liver, less likely to have disease progression. So the key is bringing everything down to what we would refer to as that stable state, where we're really trying to then do preventive as opposed to active engaged treatment.
Well, I know when it comes to treatment, there's no such thing as one size fits all, and the guidance really looks at that. So now we'll move on to monitoring. And this is where we're going to share a story, Warren's story, and it certainly serves as a cautionary tale. Hello, Warren. Thanks so much for joining us on our webinar about the new guidance for Wilson disease.
Thank you for having me. I'm glad to be here.
Well, first, a little background on your diagnostic journey. I understand that you were diagnosed way back in 1980 when you were only 7 years old.
Yes, at the time, I believe I was one of the youngest, if not the youngest, to be diagnosed. I would come home as a 7-year-old and be very lethargic and sleep all the time. Doctors thought I had chronic mono or spinal meningitis or something. And a young doctor just thought that, hey, let's try Wilson's. And he was right. He sent me and they found the Kaiser-Fleischer rings and it started me on a regimen of penicillamine.
That's right. At that time in 1980, penicillamine was the only approved drug for Wilson disease at that time. Trientine was investigational. So how did you do on that, being diagnosed so young?
I did really well. I took my medication. I was very compliant. I stayed on a low copper diet and really lived a normal childhood, adolescence. I graduated high school, participated in everything that young people do, went off to college, graduated college, and then decided I had a calling into ministry. And so I went on to get a master's degree and become a United Methodist pastor. Met my wife at seminary at Duke and got married and had a child. And so, I was living a normal life.
And that is just so encouraging for people to hear, especially when you're diagnosed so young like that. But then, unfortunately, things took a turn for the worse.
Right. My primary care physician at one point, because of the cost of the medication, I asked, could I cut my dose? And he said, let's try it. And he monitored me for about 6 months and said everything was good. So I cut my dose in half and everything seemed to be going just fine until I had an event, a major event coming up, and had this seizure-like event that really caused a lot of neurological problems to resurface that I hadn't had before. And that's when I got involved with a neurologist. My neurologist worked with me to try and get the tremors under control. And she took me as far as she could and recommended that I seek out a Wilson's disease specialist. And so she referred me on to Dr. Schilsky at Yale. And when I saw Dr. Schilsky and told him about cutting the dose in half, he said, that's the problem. And he made me this promise. He said, I can promise it's not going to get any worse. It may not get any better, but it's not going to get any worse. And he took me back up to my original dose.
And how did you do from there?
I've slowly improved, actually. I've been under his care for about 11, 12 years now, and have slowly gotten better and have been able to once again enjoy a normal life. I am unfortunately on disability because of the neurological damage that has been done. But other than that, can do pretty much what I can't, what I can do.
So based on this experience, Warren, what advice would you give to other Wilson disease patients?
If at all possible, I would say seek out a specialist. While there are great doctors out there and more doctors are learning about Wilson's disease, you really need to seek out a specialist. They know what's best, and they can help you, and figure out the disease a whole lot better. So that's the best advice I can give, is to seek out a specialist.
Well, Warren, I'm so sorry that you went through this, and at the same time, very thankful that the medication was able to rescue you again. And thank you for sharing your experience and your advice with us today.
Well, thank you. Thank you for having me.
The WDA supports Warren's advice to try to see an expert in Wilson disease at least once, if at all possible, after your diagnosis. And you can find a list of experts on our website, as well as a list of our centers of excellence. Dr. Schilsky, how does the guidance help to prevent unnecessary tragedies like Warren's?
Yeah, no, the important thing about a guidance is it really serves as a guidance. So there are first recommended dosing regimens for each of the medications. And those are, and I have to credit my colleague Eve for making me think like a pediatrician many years ago. Some of these are weight-based kind of dosing, so the dose may be different for somebody who is a much smaller individual or a child versus an adult. But the dose should reflect the appropriate dose for that individual. If you step outside of that dose, and that does sometimes happen, if somebody, it should be for a good reason. And if they're having a side effect, that may be one reason to do it. Or there may be certain biochemical changes in which that individual's reached certain milestones of treatment at an earlier point in time. Maybe they're very strict with their diet, maybe as well and concurrently. So we do have certain parameters to follow for each of the treatments, whether it's the urine copper excretion in concert with the biochemical part. But the important thing is also remember the clinical aspect for the patient. But the key is that also the other parts that we say is if you're a patient, you can recognize, you put on a proper regimen, there is an adherence that we recommend to a frequency of monitoring and testing to be done to help detect what we hope will be the biochemical changes that will be found first before a patient may experience very negative or consequential clinical changes. So I think that is really the key point is if you're on medicine, if you're changing the dose, extra monitoring may be required. And there are certain circumstances where that kind of lowering the dose is recommended. And, for instance, around pregnancy, where we may want less exposure to the fetus for some of the chelating agents. So follow those, rules. And if you're changing up the rule, you have to have good reason and a good follow-up to make sure you're doing okay.
One of the things which I think this guidance does that we did less well previously is to give some real benchmarks as to how would you assess the efficacy of treatment. And again, it's just a guidance, but it does give you some sort of signposts. This is what I should be achieving with my treatment, and if I'm not, I have to ask why. And the other thing I'd mention is a bit like Dr. Osler. Patients have a wisdom of their body, and if they don't quite feel right, that's probably worth paying attention to.
And Dr. Roberts, you still have the floor. If the treatment isn't working, what else might be going on?
Well, I think this is one of the real innovations in our attitude toward adherence in this guidance, partly to talk about adherence, but mainly to remind everyone that treatment failure is not necessarily due to bad acting on the part of the patient. There could be something else going on, and you need to consider and rule out all those possibilities before you say, oh, you're just not taking your medication. That being said, it's pretty hard to take a medication consistently for a lifetime, and we recognize the challenge involved in that.
And Dr. Roberts, the whole issue of compliance, adherence, it can be especially difficult for young patients or patients who are diagnosed before they ever had symptoms develop. What have we learned from other diseases that might help with that compliance?
Well, I think we've learned to respect the problem, first of all. We know that treating high blood pressure, for example, is very difficult in adults because it's symptomless until there's a disaster. And Wilson disease can be like that. We also know that teenagers with diabetes mellitus or cystic fibrosis or various other chronic diseases often go through a sort of time crisis when they just reject the fact of being ill. They don't want to comply with their medical regimens. And those specialists have figured out ways to cope with that time of life, and we can learn from what they do. A team approach is probably one of our best defenses against that problem. And again, this guidance really strongly advocates for a team approach.
And Dr. Schilsky, how does the guidance help to pick up treatment failure or perhaps even overtreatment?
Yeah, so Eve alluded to this before in her comments about treatment, in that when we're seeing treatment not go right, there may be other causes as well, and and specifically there may be concurrent disease, whether somebody gets a second viral illness, or they may have fatty liver disease independently, or there may be other toxins involved, medications or alcohol. And these are always in consideration when a patient's not following the charted course that we hope they would while they're on therapy. A good example may be of a failure, maybe people start with some of the liver tests like ALT or AST, which are known as aminotransferases, and often they're elevated. And then we expect that with therapy in a particular amount of time that there should be a trajectory which will be towards improvement. When we don't see that in a reasonable fashion, or if there are other development of new symptoms, again, bringing in, as Eve said, listen to the patient. If there are other clinical changes, mental health is worsening, neurologic part is worsening, we have to take that into account as well. We have to think a little bit along a timeline. And our expectation is that most of these biochemical changes will show significant changes somewhere between 6 and 18 months. And if these things are not happening for that, then we have to think, are we not achieving what our goals are? Similarly, we look at the mechanism of action of a drug, and the chelating agents per se will increase urinary copper, and the zinc may stabilize it or lower it. And if we're not seeing the guidelines met for the use of that medication, we then have to say, what are they not doing to achieve that? Is our dose off? Is the dose not being taken? Is the medication not good? Is the diet too rich in copper unintentionally? Or is there water contamination or something else? So we have to be cognizant of all these things. Now, on the other end of the spectrum comes from patients who've been very adherent to diet or been on their medicines, take them every day, and suddenly we find their, for example, a patient on chelation agent, urinary coppers go down very, very low. Is it because they didn't take their medicine that day? Not in that patient. It could be because they are now depleted certain of the stores of that copper that is normally bioavailable. So we have to then define what our expectations may be so that we can detect these findings before they have consequences, because they do have consequences. The blood counts, the bone marrow is dependent on copper, and so if we're overtreating, we may have a problem with the blood counts. Iron, which is dependent on certain cofactor of copper in the reactions to move it around the body, can accumulate in tissues. And some patients may develop new neurologic signs that are related to that copper deficiency. So all of those potentially can be prevented if people pay attention to the biochemical parameters. Now, unfortunately, it's not all one simple test, as we've learned, because some of these ways of estimating where somebody's copper at is a bit challenging these days. And so one of the things we do talk about in the guidance is a move towards newer assays which are in development that can actually get to what the bioavailable copper is in the circulation. And we think that when these come on the scene, they've been used in clinical studies already. When they come on the scene and are available clinically, we think that will help prevent and augment our current view of how we can detect these either overtreatment or undertreatment of patients.
Well, that is very hopeful. And one last question for you, Dr. Schilsky, before we go to questions that have come in from those watching today. And that is, you talked about the biochemical ways of monitoring for overtreatment. Is there anything that a patient could look out for if they're being too rigid with their diet or something else? Is there anything that they should watch out for?
Well, I think it's very difficult for a patient to know whether a new symptom is related to being overzealous with their therapy, and that's where we come in, and we would hope that some of the testing that we do, some of the routine tests can pick up this in standard blood counts. Iron parameters can be measured, and we do this certainly later in the disease as people have been treated for a number of years. But it's probably the best thing they can do is just make sure they're following their tests, and that their tests sort of fall within the not too low, not too high, kind of like Goldilocks, just right. That they want to be in the right parameter for the therapy that they're on. And if they're too high or too low, question it. Ask questions, and that's what their medical teams are there to help with.
Okay. All right. Well, the first question, I think I'm going to direct to Dr. Schilsky. With such a high percentage of Wilson's disease patients being diagnosed with major depression, are there studies being done to see which antidepressants or other treatments might work best for these patients?
Yeah, it's a great question, especially we had a recent publication that came out of the registry study that has been sponsored by the Wilson's Association, in which we did see about 50% of our patients had some form of major depressive episode during their lifetime. Now, what we've learned about use of the medications for depression, and I'll credit a lot of what I've learned and carry on from my psychiatry colleagues. Dr. Zimbrian helped write in this guidance some of that section. But we know that this has an underlying liver disease. So whatever we give has to be both liver friendly, and also it shouldn't have neurotoxic effects as well. So we've been fortunate in that people have gone before us with other liver diseases where there has been also depression overlays been concerning. And so there are a number of different classes of drugs which we know have been very safe in use for those diseases. And we can carry those over and at least start off an experience. Over time, we hope to understand better, is there A1 that may do better, in particular with Wilson disease? But we do have experience to lean on already. But I do say that's where the importance of a good mental health professional, especially someone who understands also the backbone of having a liver disease in place, is important.
And Dr. Schilsky, you do mention in the guidance that there's a very high prevalence of patients who have had some type of depressive episode.
Yes.
Dr. Roberts, I'll direct this question to you. Is it possible / common for Wilson's patients to have their children evaluated for Wilson disease? Children have no symptoms. Liver biopsies, blood work, genetic testing. This person's family had a higher than normal incidence of Wilson's disease.
Well, it certainly is possible to do that. If you know what the mutation or mutations are, because so many Wilson disease patients have two abnormal genes, but they don't have the same abnormality. But if you know, therefore, the molecular genetics of your family's Wilson disease, then you can screen everybody for carrying those particular mutations. That may not be economically feasible. It's kind of a big deal still to do genetic testing, and therefore it is certainly possible to do a clinical assessment of your children, and perhaps to sensitize your GP or your pediatrician to the fact that this check may need to be done repeatedly every year or two until you're satisfied that either there is a diagnosis or there isn't. Another possibility is to have your partner tested, because if your partner has absolutely normal ATP7B, then your offspring will be carriers, but they will not be affected, so long as, I'm speaking of one of the breeding couple, as it were, having Wilson disease and the other one being normal.
And Dr. Schilsky, this one for you. In the new practice guidance, you mentioned on page 27, you talk about just needing to be mindful of your copper intake when pertaining to the liver, but several neurological patients experience adverse effects from eating too much copper. Have there been any studies to that capacity?
Surprisingly, there are a few studies where there have actually been proper copper balance studies, but what really matters in the end is the real world experience, that patients being treated on whatever their particular diets may be, and whether or not they are avoiding the highest copper content foods. And it's certainly what's true for the liver patients is certainly true for the neurologic patients, because the underlying basis of the disease is the copper transporter in the liver, that when that's not working, then there's overflow of copper that ends up coming into the central nervous system. So they are correct. It applies for all the patients, whether it's mental health, neurologic disease, or it's liver disease.
Well, Dr. Schilsky, this patient has really studied your guidance. There's another one where she says, in the new practice guidance you mentioned on page 17 in figure 3, the algorithm for diagnosing with symptomatic neurological Wilson's. What are we doing for outliers of neurological WD without KF rings?
So there, first, as Eve mentioned earlier, most of the patients with neurologic disease, it'll be over 95 to 98%, will have Kaiser-Fleischer rings. There are rare outliers. Guidances, remember, are made for the 90%, not for the 110%. It's very hard to have an entirely one-size-fits-all. But the other things that are very helpful when something doesn't fit the bill entirely is sort of encompassed by parts of the algorithms where we have that sort of gray zone, and this was Eve's great idea to sort of generate how we start to look at the patient that may not fit exactly into a single niche. Now, the advance that's really helped us with these patients that don't fit the niche entirely has been the molecular diagnosis. And so while it's imperfect and we do not find all the particular mutations in all patients, some of this is technical in that we're not sequencing all the areas of the gene and upstream. Most of the time we're sequencing coding regions, but there may be influence of different parts of the gene as well, or upstream regions to the ATP7B. But be that as it may, simply there are other things that may affect the expression that we do not identify all the time. So the genetics form one important part of the piece. And the other thing that we lean on, and we do mention in our algorithms, is using the different parts of the Leipzig score as well, which is a scoring system that was put forth by experts back in 2003, which is a combination of clinical and biochemical findings. And on top of that, each one is sort of granted a certain weighted response in terms of a number. And we can go through that very systematically, and the algorithms include those for reference so that people can look back and forth. And so you really should then be very detail oriented, and you may still come to a point where you're confident in the diagnosis as well.
Well, I have a couple of lifestyle questions to ask each of you. Dr. Roberts, in the guidance, you specifically point out that patients should maintain a normal weight and get good exercise. And beyond the obvious reasons, why is that important?
Well, the obvious reasons are pretty persuasive to start out with, but in point of fact, we are very worried about this other liver disease called non-alcoholic fatty liver disease, which can really be very severe. And of course, it's hundreds and thousands of times more common than Wilson disease, but the two disorders share the possibility of damaging mitochondria. And those are the power-producing organelles in your liver cells and in other cells too, but we're interested in the liver. And so if you were to have an obesity or insulin handling related problem in addition to Wilson disease, you might actually have more severe liver disease. That can be avoided by maintaining a good body size and also getting enough exercise.
And Dr. Schilsky, this is not referenced in the guidance, but it's a question that I think almost every Wilson disease patient has, and that is about alcohol consumption. What can you advise?
Well, I'm afraid I have to adhere to the party line of telling people not to drink. And the reason is very similar to as described by Eve and for other things that may injure the liver, in that the site of injury for some of the toxic byproducts of the alcohol goes down to mitochondria in the cell, and that's the same site for copper injury. In addition, there's fatty deposition. That probably is a consequence of the mitochondrial injury that arises from that as well. So it's a little bit like pouring gasoline on a fire, so we usually don't recommend doing it. The problem is, it's always, some people say, is it really a how much question? And part of the problem is really gauging whether somebody will listen a little bit or listen a lot if you do tell them to moderate or have a rare drink. And this is always a very difficult position to take. So this is why you'll find most of your physicians taking the more extreme, just don't drink kind of position. There was a question if a patient is on zinc therapy, whether it's common to go on and off due to overtreatment, and the answer is usually not during the early phase for a patient, but after many, many years, there are a number of patients who can become depleted of copper. Again, a lot of that depends also on how adherent they were to dietary copper restriction at the same time, because the zinc can be overridden with a very high copper diet. So the answer is it can happen. It's not common to happen if the dose has been looked at during the years. One thing I would say it's to be very careful of taking it less than the prescribed amount of time. It's better to reduce the dose, take it more frequently, and monitor than it is to experiment with once a day or once a week kind of dosing. That's just not going to cut it. But again, I'll go back to the same principles we set forth in guidances over the years. Whatever you're doing, monitor it. And if you make a change, monitor it more frequently. And so if you are, you won't get into trouble that way. Eve,
and in general, the changes should be modest. So that you cut back a little, or you make a very gentle change and assess that before doing anything else. A modest change may be all that's required. And I'd just like to point out that I've always worried about teenagers and zinc, because I have rarely met a teenager who was 2 hours away from eating anything. And so we really have to figure out ways to make it easy for teenagers in particular to take their zinc properly. And to me, that is always a challenge.
There was another question about availability of one of the branded forms of zinc. And one of the things that, we do mention in the guidance that, there are multiple forms of zinc that have been used by patients. And this is supported by other retrospective studies in the past as well that have good absorption of the zinc and prevent the copper absorption. So there really isn't an excuse just because I couldn't get my one brand that I couldn't be treated during that time. There's also a question from, it must be a UK colleague, about the guidelines and whether these could be implemented in the UK. You should be aware that a year ago, the UK put out forth its own Wilson disease guidance. But I think ultimately We looked at other multiple guidances that were out there during the preparation of ours, and I think there should be updating over time, and potentially, as we have better data, homogenization of the best ideas for the guidance. What they have in England, which is a really very interesting way of parsing the drugs, is actually also only experts designated at certain centers can actually prescribe and distribute the medications. And this has been done in over a number of years now to support appropriate dosing, prevention of things that, for instance, that Warren experienced, and preventing overtreatment or preventing incorrect administration of the medication. I don't know how well that would go over in the United States, but it certainly has been something that was implemented there, and it's an interesting way of doing things, and we'll have to see if that is really successful in achieving the goals.
There is a question about gene therapy, and that really isn't mentioned too much in the guidance. Dr. Schilsky, what can you say about that relative to the guidance?
Well, we do mention that these are new and there are new and developing therapies, but guidances are really meant to review what is available from before, and when things are on the cusp, we are often allowed to say. So within the scope of a guidance, we weren't allowed to say very much. That said, ultimately, right now, the only thing that provides a cure and is a different problem is a liver transplant, and that sort of has been the understanding, or at least sort of the almost a pivotal life experiment that tells us that someday gene therapy and CRISPR, if delivered to the liver cells, will probably be successful in reversing the problems for copper overload. Now, how we get there, and can we get there very effectively? We hope so. Time frame, good question, but we're a lot closer than we used to be.
And Dr. Roberts, there are a couple of questions that have come in about COVID. Has anything been learned about COVID and how it affects people with Wilson disease?
Well, not that I know specifically. Most of the work I think about that's relevant with COVID is how COVID complicates established liver disease. And I think Dr. Schilsky knows more about that than I do. And it's important to recognize that liver disease might be a problem with COVID. So I will ask Dr. Schilsky to comment.
Yeah, thanks, Eve. Actually, I sat on the task force for the AASLD for our COVID task force, and it became very clear early in the pandemic that advanced liver disease suffered much greater mortality and morbidity than patients whose liver disease had been well controlled. And this was true of all the diseases of the liver. And so, none was spared from that. So Wilson's didn't get a super protection, and it didn't, neither did it, have any underrepresentation in the mortality for those with advanced disease too. There was an interesting period of time when people thought that zinc might be helpful. For COVID, it actually created havoc in the Wilson disease community, because then suddenly the supplies of zinc went off the shelves, much like toilet paper did in the early days. And I felt badly for my patients who wanted to go keep their zinc stocks up. But this abated fairly quickly when the evidence wasn't very strong that it changed anything. And so that was an unintended consequence. But I think you're absolutely right. Our data so far has supported no difference, although we have some interesting other dynamics that are interesting that we've been surveying about patients during the pandemic.
I guess the one thing I would speculate is that I can imagine a patient with Wilson disease who has had COVID thinking that the symptoms are long COVID and it's just going to go away and it's not a big deal. So I would worry a little bit about delayed diagnosis because of blaming everything on COVID or not having easy accessibility to physicians. And perhaps we should be thinking about that.
Well, actually, you nailed it for one of my patients, Eve, who did experience that. And the doubt went up in her mind as to whether indeed it was related to the COVID or some, under treatment or other complication of the Wilson disease. So, yeah, that's absolutely correct. Fortunately, those are rare occurrences, and hopefully less and less into the future.
Okay, and we're getting close to the end here. We have just 3 minutes left, but Dr. Schilsky, perhaps you could take this question. This person has been on DPEN for 45 years with great success and wants to know about adding zinc, and what I would kind of add along with it, because I think you've touched a little bit on this, on switching treatments, and we know some new things are coming down the pike. If it ain't broke, don't fix it kind of attitude. When should somebody consider perhaps a change?
Well, changes are made either because they have to be made or because people wish to do so. Sometimes the changes occur because in some countries many medications may not be equally available, or there have been on occasion, hopefully less and less so, supply interruptions. And so in which case it's wonderful to have multiple alternatives to turn to. So it's really an individual's preference of between them and their physician, whether they feel the change is going to be potentially beneficial. What we talk about more in the guidance is changing when you have to change, or if you do change for reasons of your own choosing. The key is really to understand that you don't really need to do any of these slow down on one, ramp up on the other. You can make the change, especially in somebody who's done well over many years, make that change instantaneously. But whenever you do change, make sure you're still achieving the goals of the therapy that are appropriate for that medication. So for instance, this person who asked the question is on penicillamine, so we assume they're running a high urine copper at this point relative to a normal. Yet if they move over to zinc, the expectation would be that it would not remain in that same zone. So then they need to readjust what the parameters are that they want to achieve. And then hopefully the backbone of everything else, their clinical and biochemical status of stability as we might measure it, should hopefully remain the same. And the key is then, making sure that when you change, you tolerate it. Because we have had people change therapies and then find that they have not tolerating the new therapy well, but then there often is then a little confusion about how and when to go back or choose to look even for another alternative therapy. All these are fair points, but in the end, you have to find something you're going to stay with and then understand how to use it properly.
All right, we're coming up on the end, and if you would each just take 30 seconds, Dr. Roberts, just the final message you would like to leave with those watching today about the new guidance.
Well, I think the new guidance really helps you to feel confident that your physician can help you to have effective treatment. And what we know about effective treatment, that's treatment that's not only efficacious, in other words, it works, but you actually use it and benefit from it, is we know from numerous studies that the expectation is for a normal life expectancy and a healthy lifetime on treatment. So we really want to achieve that. If we have new drugs coming down the line, as we do, although they're not quite ready for distribution yet, what that's really saying is we can individualize treatment even more finely than we are already. And that's a very exciting prospect, but it still gets back to having effective treatment that works for you.
And Dr. Schilsky, final thoughts?
Well, I think the key is that guidances are not ironclad, that there can be individualization and must be individualization, that no guidance can ever be written to encompass 100%. But the important message that we wanted to deliver, and I think we covered that right in the upfront, is that this is a team approach and that sometimes it takes a village to get where you need to be, whether it's neurology help or psychiatry help. And importantly, what we haven't discussed today was family and caregiver help, which I think is very critical and form part of that team that can help assure the patient achieves their goals in getting therapy safely and then gets all the appropriate monitoring. And so these will evolve. And I think the key is that, and this is a third iteration of the AASLD guidance. I think each one has gotten better and each one has kept us very humble about understanding what we've achieved with it and what we need to achieve still in the future. So we really appreciate you taking the time out to talk about this more today. And I know it was a labor of love, and it's been great working with Eve and my other co-authors on this, but especially with Eve, who I've shared now. This is the third time.
And also want to thank the 7 other co-authors who contributed. And I know all of you just put a number of years actually into putting this together. And thank you for doing it on behalf of all of us with Wilson disease. And a question did just come in, again, asking where to find the guidance. So if you missed that at the top, where we mentioned it's on the WDA's website under diagnosis, which is under the Do I Have Wilson disease tab. And Dr. Michael Schilsky and Dr. Eve Roberts, thank you both for joining us today.
Thank you.
Thank you, Rhonda.